respected chairperson, sirs, distinguished faculty, and my dear friends, I am indeed most humbled and I feel very, very privileged to be here today sharing what I have learned over the past 3 decades. I love what is written there below TSMISS 2023. It says the power of healing. For me, the power of healing is when the Jeev Atma in me, that means the small part of me, reaches out to the Paramatma in you, which is the God in you. I am here just to show you a mirror. I am not here to preach. I am not here to say something is good or bad. It's not judgmental. It's what I have learned over the years, and I share with you my journey over 3 decades. I begin with John F. Kennedy. John F. Kennedy was born on the 29th of May 1917. He was the 35th President of the United States of America. He experienced chronic back pain. He underwent 4 back operations when he was born more than 100 years back. He underwent 4 back operations, including a discectomy, an instrumentation and infusion, and 2 relatively minor surgeries that failed to significantly improve the pain. Unfortunately, this visionary was assassinated on late evening, 22nd of November, 1963, in Dallas, Parkland. A few hours later, on 23rd of November, 1963, at 5:30 a.m., in a small little city in Mumbai, yours truly was born. I really don't know whether it is connected, but I share my journey, which probably began somewhere with a back patient ending his life not on his own, but getting assassinated. I have learned over the last 3 decades that this statement that we all begin with, that we can make unhappy patients happy as spine specialists, is probably something that needs modification. I've learned over the years that I can only make unhappy patients less unhappy for some time. Please think. About 20 years ago, when I started doing laparoscopic surgery, I believed that minimally invasive surgery would be a mid-path in between non-surgical and surgical options. I was wrong. Minimal invasive spine surgery is the present and the future of spine surgery. We need to understand and accept this reality, which is not a myth, but is a truth. I was always told spine surgery is an event. It's not a process. Just do your job and go home. Ladies and gentlemen, spine surgery is a process. It begins from the moment that patient steps into your clinic or has contacted your secretary or visiting attendant and is coming with hope, which you need to confirm and convince him into belief till he finally puts trust in you to undergo surgery and hence live up to what he came with as transparency and truth. So we keep discussing the what and the how. We keep discussing the product and the process. Very rarely do we discuss the why of spine surgery. What's the purpose of that spine surgery? Dear friends, the decision is far, far, far more important than the incision in spine surgery. I always said I'm a surgeon. I had that chip on my shoulder. Why should I involve myself in non-surgical care? 95% of our job is non-surgical. You got to hand hold that person in pain and walk him through till he gets relief and indulge in connecting with him, empathy and compassion. I always thought I know more about spine than this particular patient. Hence, I should be having a higher or a greater say in the informed, shared decision with the patient. I always felt 51% at least should be mine and 49% should be with the patient, his caregiver, and the family. I am wrong. Gentlemen, let the patient buy the operation. Never ever sell it to them. Please remember, you have to always do surgery for outcome and not for income. It is extremely, extremely important. Why do I have a team for surgery? I can carry my scope in my rear pocket, walk around, open it somewhere, put in those scopes and walk out. No. Spine surgery is not an individual sport. It's a team sport. Team is an acronym. TEAM, together everyone achieves more. Right from the person who saw the patient to the final physiotherapist helping that patient at home recover. This is the team. We are just a small cog in that wheel. We have to play our role. We are not the ones who are commanding and dictating the entire process. Work as a team. Now coming to what I feel is getting sidelined. Most spine surgeries do not need an ICU. In that case, most cars do not need airbags or seatbelts. If you are seated here, it's not because you never worn the seatbelt. It's that either because you worn the seatbelt but have not used it, or the airbag has not needed to be opened. And if it was open once in a while, that's the reason that we're here. Please remember, whether it's an airbag, whether it's an umbrella, whether it's a parachute, whether it's your mind, it only works when it's open. Keep it open. Don't have closed, fixed ideas. I love it. I love it because this is an association where I know that 50% are neurosurgeons and 50% are orthopedic spine surgeons. I am an orthopedic spine surgeon. And I stand here saying something which many of us feel otherwise. Please be wise and not otherwise. I do not need a neurosurgeon. No way. The patient deserves a team of the neuro and the orthopedic spine surgeon. Work together. Elvis Presley was a great performer. So were the Beatles. Presley worked alone. The Beatles were four. Please remember, work as a team. If the patient deserves a neuro and an orthopedic spine surgeon, work together. If I were the patient, put yourself in their shoes, would you not want the best team does intramural work better than I do. I know he can salvage things when there has been an adverse event better than I can. Yes, he also respects me for the few things I do with the world around. Hence we work as a team. Always remember, let go. Let go of your ego. Ego is a vain, an acronym. Ego is EGO, ejecting God out. Let go and let God dictate the way forward. Neuromonitoring. The last thing which came into this used to be 9 mistakes, which became number 10. We thought neuromonitoring does nothing. Well, neuromonitoring is the way forward. Use it. Even if it takes 25 minutes at the beginning of the surgery, it adds to the expenditure. But listen, life is invaluable. Far, far more worth. And every neurological level saved is always better for the patient and for you to sleep well at night. Please remember, we deal with very, very critical areas, and neuromonitoring is an integral part. Having said that, I always end with this presentation, but normally now I begin with it because I believe this is what is more important than anything that will follow after this. Gentlemen and ladies, just like I said, operate for outcome and not for income. I also say only operate for need and never for greed. Please keep that at the back of your mind. It's been 33 years since I embarked on this journey. I shared those unhappy patients who taught me the most. What's the aim and objective of my presentation? It's not just going through spine surgery, but growing through spine surgery as a team. Failed back surgery syndrome. I don't know how many of you have this discomfort that I do. Have we got failed fracture surgery syndrome? Have we got failed cardiac surgery syndrome? Have we got failed joint replacement surgery syndrome? Oh, then why failed back surgery syndrome? That word failed is like wearing something on top of your head which says, this guy is responsible. No, we're not. We're not. There's some way that we have to come across till we reach out to the I have analyzed over the last 3 decades the mistakes that I've made, the lessons that I've learned. And as I shared with you what was information first, then with my integrity and intrigue, I confirmed and went to information and made it knowledge. And then I had too much of knowledge, so I throw most of it out and kept a little bit, which is wisdom. That wisdom is what I shared with you today. This is my professor. He turned 86 on 13th of October yesterday. This was when he turned 58, the day he retired from our medical institution. That's yours truly, the gentleman right now to the left in the front. I was there, and what did he teach us? He said, convert all your adversity into advantage. When life gives you lemons, make lemonade. So what's my team? As mentioned, orthopedic spine surgeons, neurospine surgeons, and fellows in pursuit of spine surgical knowledge. I shared with you 30 years, 91 to 2023. 228 patients analyzed. These were divided broadly into 3 categories. The first, 90 patients out of 228 who had obviously something visible to the eye, hardware issues. Category 2, nothing visible to the eye, but obviously there is something wrong which could be picked up with either imaging, electrophysiology, or both. And third, 66 of the happiest people. Nothing seemed to be wrong. Whatever tests we did, everything was normal, normal, and normal. you about. There were patients that I had operated, my team had operated, which came back to us. There were patients who were operated elsewhere who came back to us. Only thing in common is that all these 228 people were symptomatic enough to be asking for buying yet another operation. So they were all so unhappy. Everything had been tried. And they said, "Doc, if you need to operate on me again, please go ahead." Category 1, 90 patients. What did we have there? As I said, obviously wrong-looking stuff. Well, what I'm going to show you will surprise you. Don't ask me how and what was done for this patient. I still don't know. I inherited this. And believe me, if you have inherited this, and there is neurology, which is now slow in onset, and the patient is about 3 years post-index surgery. Don't ask me what to do in 3 years. I don't know what to do. It's a big challenge. How do you get this out? Or if somebody travels across the border and comes to your country with an implant that looks obviously going through a root or invading the root, and you have border issues with that country, you have to be extremely careful before you embark on a journey to try and correct it. Well, what did we do? We removed the first one, and as you obviously see on the corrected CT, we repositioned the second one. There was some that I did. This was in the year 2000 when the first indigenous Indian implant for an interbody spacer was made out of titanium. I helped devise this locally because we could not really afford the stuff that came from overseas. Unfortunately, this patient, a holy saint himself, believe me, he agreed to get it done on him, was done by me. This was surgery done by me 2000 or 2001. And I realized when he came back to me at 8 weeks that he had recurrent same-sided neck pain. This saint had borne it all, but I could not bear it. The entire implant had slipped by 90 degrees and turned around. What did this patient treat? I said to him, he said, "Doc, take it out and be fine." I took it out, and lo and behold, when I put my pen-filled retractor into that disc space to feel, at 8 weeks, it actually started throwing good bone anterior vein. When I didn't replace an implant, I just added a little bit more of autogenous graft, and he did settle. Now I come to the second one, the one that hits me, where I don't see things obviously on X-rays or imaging or something that is sent to me from somewhere, but somewhere where I can think, was there an adverse event? Was it something amiss that happened during the operation? A durotomy, a large excision? Was there any cystitis suspected? Or was it this new kid of the block called adjacent second disease? I say new kid because this started 25 years back to me. Well, if it was sepsis, huge, humongous back and front surgery for infected spine, tuberculous in nature, however, developed a secondary non-tuberculous pyogenic infection and came with a neurology at the end of 6 months, again from overseas to us. I went and cleaned up the rear, got that pus out, gave a complete lavage, maintained the anterior implants, removing the posterior implants, and he did settle neurologically with an arterials and was an arterial. Now coming to the case that taught me the most. Journey began in 2002. As I told you, I was an aggressive spine surgeon. This looked like an L45 anesthesis, sacralized L5. Because I had flexion extension, I found there is some movement there. For that young kid, that movement was enough to try and restore the anatomy back. I went in. I had to decompress 2 levels. I was also working on this knurled rod at that time, a soft flex option. So I did a rigid stabilization in the lowest mobile segment, decompressed the level above, and put in the knurled rod there. So I allowed physiological loading at the higher level with physiological movement, but prevented supraphysiological so, because I was convinced that we need to do this as a routine to prevent ASD, adjacent septal disease, 25% radiological and 10% symptomatic ASD. I was so convinced about it till this man in 2002 taught me otherwise. I realized that there is an adjacent level, adjacent to the level that we have predicted. What happened? I predicted L3, 4, I fused 4, 5, but 2, 3, lo and behold, was involved, despite some physiological loading being allowed there. What did I do? I changed my school of thought. We don't respond, we react. We don't give it a thought. I pulled that rod out, went one level above, and did a complete 3-level instrumented fusion. One interbody and the other posterolateral. I told this gentleman, Uncle, don't worry, you will do well. This is 2002, which had now gone on to 2004 or 5. That's when he came back the first time. He said, I said, don't worry, Uncle, you do great, don't worry. He became a good friend of mine. Once you operate for the same patient twice, they become the best of your friends. Having said that, a couple of years later, 2009, he had also grown older, so had I. I treated his wife with teriparatide for an osteoporotic orbital pressure fracture, and he came to me and said, Doc, what you treated for that pain is now happening to me. What's wrong with me? Did the imaging? And of course, things were working against me. I convinced myself this was the wrong level to stop at. You can't stop below the thoracolumbar junction. You should have gone across the thoracolumbar junction. I said, Uncle, I'm sorry, but we need to go again. He said, why? I said, for your pain. He said, but give me that injection, that one injection for 2 years. But I still did it. We did his DEXA, confirmed that he was borderline osteoporotic at his request and with a PTH being normal. He started him on teriparatide. The pain did not diminish. Having come back, he said, okay, young man, go ahead. So I went ahead and I said, this time I'll go right across the thoracolumbar junction. I won't stop anywhere short of B9 or B10. And that's what I did. I went all the way across to the thoracolumbar junction, went up to B9, and said, Uncle, it's done. You are now even better friends. It was 2010. He said, good. Now I'm feeling better. I'm having a little bit of chest pain. Should I go to a cardiologist? I said, no, don't worry. He went to the cardiologist. The cardiologist said, listen, you're okay, but you undergone these major surgery. Just stay away, you'll be fine. And so it passed. He then started moving around, doing exercises. 2 years, and he came back one fine day saying, son, I walked into your clinical career. Today I can drop on a wheelchair. I cannot walk. Since when, Uncle? Since a day and a half back. What had he done? He popped out a disc. He popped out a disc at the lower thoracic level, D8, D9. I said, come on, this should not be happening to you again and again. There's something amiss. What did I do then? Well, I again convinced him. I didn't have to, he convinced me. He had 3 successful ventures with me. He said, let's go ahead and do something. I said, sure, we'll do it. Now I went, scratched my head. I never had this earlier. I went across the thoracic spine, right up to B4. And I said, this is the way to go. We have to confirm, and we have to have a good spinal pelvic balance. I'd learned about it. So I went up and I went and put an implant right up to D4. So it was D4 to L5 and L5 being centralized. Having done that, I said, Uncle, it's all over. It's now 2014. We are doing well. I think you should now review yourself. You have taken physiotherapy and recovered. From a non-walker, became a walker. From an uncontained bladder, he had complete control over his bladder and bowels. We were happy. Till one fine day, I was overseas attending one of these meetings and I got a call. Uncle is back. What happens? He's lost sensation and full control below his mid-chest. What did he have? I said, nothing can go wrong now. It's a rigid part of the thorax. Nothing can go wrong. He can. He had popped a disc at the D3, D4 level and he had shut down completely. I said, I told my team, just go ahead and do the surgery. He said, no, Uncle wants you to come back. So I flew back. I was thinking all about it throughout the flight. This time you got to do something more. He said, yes, I know. Do something that's the best. I said, okay, let's put screws and wires. So I put screws and wires right up to D1. And that's precisely what I did. He had a D3-4 where he had shut down. I went up to D1, put in screws as well as sublaminar wires or wires going around. He asked me, son, it's been 5 surgeries, it's been 15 years. Where are you going next? I said, I don't know. He said, here's what I did. My cardiac procedure is waiting, should I go ahead? I was skeptical, but the cardiologist was insistent. 6 months after the surgery, we went for a cardiac procedure. Uncle never came back from a cardiac procedure. We lost him. I have no answer. Had Uncle come back? What would I do had he moved at the cervical thoracic junction? This man taught me everything that I needed to know about TSMISS. But he also taught me what I execute in this, the last part of my presentation, with those 66 patients. You don't know what is happening. You cannot do anything about them. They are burdened with the perils of the past and the fear of the future. They are not pragmatic about the present. The patient is out of focus. It's usually the caregiver who has peering eyes looking into yours and who have no answer. These people need only communication skills. They do not need medication. They need advice and counseling. They need time. Depression and anxiety, fear of the future, and terrors of the past. What do we need to do? 9 components of effective communication. Listen to your patients. Respect their views. Have open communication about all treatment choices. Discuss all management options, surgical, non-surgical, the pros cons of surgical, the pros cons of non-surgical. Allow them to ask questions. There is no silly question. Let them ask a question. Ensure that they answer. Be aware of their language. Accept all cultural influences and compensate for communication skills. Mehrabian said that communication is 7:38:55. What is 7:38:55? It's 7% verbal, the words that you speak. It's 38% vocal, the way you speak, the tonality, the voice. And 55%, it's your body language, usually. The verbal, 7%. Vocal, hands, head. And 55% comes from the heart. That's your body language. I have followed revision measures like I shared with you in category 1 and category 2. Category 3, I've tried everything from physiatry to sending it to my brain specialist colleagues to getting them functionally evaluated. But at the end of the day, we have to hold their hands and nobody else. If I were to admit the first category where I knew the cause would go back home in 4 days, the second was some soft tissues, stay a little longer. But this last group, even if I admit them, they go back unhappily at the end of the week, not knowing what's going to happen next. Yes, some of them knew tissue events when operated. Some of them had unplanned intervention surgery when I reoperated. And in my results, as I always said, I don't like the 1 and 2, they're okay. It's the 3, which are only 56%, 44% are still unhappy. Despite what we do. What do I do if we have back surgery today? Well, as I told you, category 1 is the best, category 3 is the worst. I do a proper risk-benefit ratio evaluation. I discuss with each patient and family before about any complex procedure, which is a much longer process rather than the index surgery. I tell them that it is much longer. I counsel with a very clear intent to treat and avoid risk Fridtjof Nansen said in 1921. He was a Norwegian explorer and he said, what is difficult takes a little time, what is impossible takes a little longer. Yet I failed. And so I today follow what Simon Beckett said. Ever try, ever fail, no matter. Try again, fail again, fail better. Gentlemen, we are scientists, yet we need to pray. We need to believe that we are just instruments of a much higher force. We are not the doers. We are just instruments of a much higher force. We have to decide when to hold on and when to let go. And I decide that by saying this prayer every day, especially when I struggle for surgery. This is the Serenity Prayer by Ryan Weaver, and he said, God grant me the serenity to accept things that I cannot change, courage to change the things that I can, and wisdom to know the difference. Ladies and gentlemen, we are surgeons. All we can do is change the anatomy. We can change the structure, and we can hope that that change can improve the physiology of the function. We are all striving towards excellence, but we have to remember that we still live in an imperfect, impermanent world. Please accept your impermanence and be proud of your imperfections. Thank you very, very much for a very, very patient.
Thank you, Dr. for the interesting talk. I have several questions for Dr. Ram Chaddha, but our time schedule is severely delayed, so I would like to, I think that everyone in the audience will have a lot of questions to discuss with Ram Chaddha, but we are severely delayed in the schedule, so maybe we can talk later. We mentioned that we have a free area in the second floor outside of the building. We have a very beautiful and very good free area, and we can have a very good talk there.
Present to the society. I'd like to present our
certificate for Dr. Ram Chaddha.
Thank you.
Thank you.